Good afternoon. It's my pleasure to welcome everyone who's joining us here today, and also to our friends and colleagues who may be joining us via the webcast. I am Lynn Goldman, Dean of the George Washington University School of Public Health and Health Services, and I am delighted that you have joined us to discuss the future of public health education and to hear from our distinguished panel of speakers. As the Dean of Public Health, I am very much concerned and invested in how we educate future generations of public health students. Whether at the undergraduate or the graduate level, we must prepare our students to handle the health problems of tomorrow. Public health has changed dramatically in the last century, and it's time to re-examine our curriculums to ensure we are delivering an education, research, and practice experience that is vibrant, viable, relevant, and realistic. I just moderated a panel discussion this morning in this same room on the topic of mHealth, looking at ways that technology is impacting health outcomes. We could have never imagined the use of smartphones as a public health intervention tool even 20 years ago. And our population is changing. It is aging rapidly, and consider this, approximately 50% of the public health workforce is predicted to be on the verge of retiring in the next 5 years. We must ask ourselves, what should we be doing to meet the public health challenges of the 21st century and beyond? Today, you will hear from several experts who will address these fundamental questions, and we will follow the remarks with a panel discussion to give everyone here a chance to engage in dialogue with our experts. But first, I want to introduce the woman who is leading the charge, barnstorming the country, if you will, encouraging public health communities to begin framing solutions. I am so thrilled to have Dr. Donna Petersen here today. Donna is Dean of the College of Public Health and Professor of Global Health at the University of South Florida. She earned her master's and doctoral degrees in maternal and child health from the Johns Hopkins School of Hygiene and Public Health, which of course is now the Bloomberg School of Public Health. She is chair of the Education Committee for the Association of Schools and Programs of Public Health, and she is leading the task force Framing the Future, the Next 100 Years of Education for Public Health. Please join me in welcoming Donna Petersen.
Thank you, Dean Goldman. Hi, everybody. Thanks for having me here today for this discussion, this very important conversation that we're having, as Dean Goldman said, all around the country. I go wherever anyone will invite me, give me an audience and a podium, and we talk about the past, our experiences in public health education. Most importantly, we talk about the future, and it has been my pleasure to chair this effort. Does that work? Whoops. What am I pointing? There we go. All right. So we are traveling the country, seeking input. But more importantly to me, it's that we need to have these conversations at the local level. Our goal with this task force is not simply to write a report. Our goal is that by the time we issue the report, the change is already taking place, that the report is actually old news. So having these conversations is extremely important, because this is where change will happen. Change will happen at the George Washington School of Public Health and Health Services and all across the country, not because we wrote a report, but because we engaged in this important discussion. So I'm going to give you a little bit of background about why we got here, why we formed the task force, pose some questions for you to consider. We'll hear from our panelists, and then hopefully we'll hear from you, and I am eager to hear everything that you have to say about this. So the Framing the Future Task Force was created almost 2 years ago. We started with about 20 members, and then people heard about it and asked if they could join, and we decided to be open and to be inclusive. So we now have quite a large group, and they're from all different parts of the public health community, as you would expect. A group that large, though, is too large to actually be a working group. So what we've done is form expert panels around particular topics of importance to us to enable us to get the work done. So the expert panel on undergraduate education in public health, and I'll share some of their results. They're actually done with their work. There's an expert panel on community colleges. Your own Dick Riegelman is the co-chair of that expert panel, and they're doing some great work. And the MPH panel is almost done, and I'll share a bit of that work. We are about to launch 2 more expert panels, one on the DRPH, and one that we're calling Public Health in All Health Professions Training, which is a mouthful, but you'll see where that came from as I go through these remarks. And then about halfway through this process, it dawned on us that we really needed to hear from all the types of employers that employ graduates from schools and programs of public health. On the task force, we have the American Public Health Association, we have the state health officers, the local health officers, we have some foundations. But in fact, our graduates go all over the place. And so we needed a way to hear from those employers. We didn't want to make the task force a 100-member or 200-member task force, so we created an advisory council of employers, people from the military, from the healthcare sector, from insurance companies, from the private nonprofit sector, community organizations, and so on and so forth. So that's been a wonderful group to reflect back to us some of the work we're doing and also to steer us as we go forward. So why did we do this? Well, hopefully you all have read the Welsh Rose report. You should read it every night before you go to bed, if you haven't read it. If you haven't read it, I would encourage you to read it. It's not a very long report, and on the Delta Omega website, which you can find via the ASPPH website, is the report with an overview by Elizabeth Fee, who's a public health historian at Johns Hopkins Bloomberg School of Public Health, and it's a very interesting story of where we were in this country at that time, how the deliberations unfolded, and why they chose the path that they chose. So that's all I'm going to tell you about it. You'll have to read it yourself to find out what it says. But if you see, that report was written almost 100 years ago, and it laid out the blueprint for education in public health in this country, and it just seemed to us that maybe it was time to rethink that. So let's look back over 100 years. So in 1915, there actually were a few public health training programs, and I think my friend Joel Lee, who has more time on his hands than I do and has done a lot of this research to try to find these. There was a program at Wayne State, there was a program in Wisconsin, the Harvard MIT School for Health Officers existed at this time, and the University of Georgia had a program. After the Welsh Rose report, schools formed quickly thereafter at Hopkins, at Tulane, and Harvard. The 3 of them like to argue about who was there first. The rest of us don't care as long as we're invited to the parties when they have when they come together to talk about their histories. But what was going on in 1915, if you read the Welsh Rose report, what it said was we really need to develop MPH programs and DRPH programs. They were very clear that the science of public health needed to be cultivated as well as the practice. So there were MPH and DRPH degrees. Today, we offer an array of degrees across our schools and programs in this country from the bachelor's level all the way to the PhD and other forms of joint degrees, different kinds of master's degrees, all across the board, depending on local resources, local needs, the demands of the field. In 1915, the majority of students had MD degrees. That was what the Welsh Rose report suggested, that what we needed to be training was physicians to do public health work, to serve the role of health officers. If you can think back to 1915, there weren't state health departments all over the country. There weren't health departments in communities, but they were growing, and we needed people to lead those. So it was predominantly training after the MD degree. Today, as you know, just looking back on all those degrees, you know that we are training people who come from a variety of backgrounds, a variety of experiences. They may come directly to our undergraduate programs from high school. They may come to us after years of experience in the public health field, but it's a completely different type of student than it was 100 years ago. In 1915, as I said, most of the graduates went on to be health officers or to lead other health organizations. Today, we know our graduates, as I've already said, our graduates go anywhere and anywhere that people appreciate the skills that they bring, the knowledge that they bring, the values that they bring, and they work all over the place, and that's a good thing. Except that it makes it challenging for us sometimes to define what the public health workforce is and to enumerate that workforce and then to assess perhaps their education or their continuing professional development needs. That's a challenge. That's why we put that employer advisory board together, so we could get input from all of these different sectors. Now, ASPH at the time, now ASPPH, got involved in this in the 90s, early 2000s, with the development of some competencies. And this was in response to an Institute of Medicine report, and I haven't gone through, there's a whole parallel movement on the part of the IOM, starting with the 1988 report on the future of public health. They've done other subsequent reports that speak to the needs of education and public health. But ASPH got involved first by developing the MPH core competencies, and these have framed a lot of the public health training that has happened since then. Again, they reflect the vision of the 1915 Welsh Rose Report, but this was an attempt to really to clarify what we thought core competence was in the MPH. Once we developed those MPH competencies, we then went on to develop DRPH core competencies, some particular within the MPH core competencies in preparedness and in global health, and then we created what we called undergraduate learning outcomes. And we had put an undergraduate task force together, partly, or largely I should say, in response to what we were seeing out in the field, that we were seeing undergraduate public health degrees emerge, not in schools of or programs of public health, but outside that sphere, in colleges all across the country. And we said, well, does ASPH have a role in that? Should we be participating in those discussions? Is there something that we should do about that? And we got together and decided, yes, we should. But we were captivated by this idea of, what if every undergraduate could be exposed to public health and learn something about public health? How much easier would the public health work that we do as professionals be if the public had a greater, broader understanding? So we developed the learning outcomes, which are designed to do just that, to create opportunities for undergraduates to be exposed to public health values, concepts, ideas, skills, in any part of their curriculum. And we were very excited about that. So at this point, we came together and said, you know what, there was now a groundswell of interest in having ASPH develop parameters for undergraduate degrees. They said, yes, learning outcomes are nice, but we really need you to tell us what these degrees should look like. The MPH competencies were at this point old. You're supposed to review them every 3 to 5 years, and at this point they were well beyond that. The DRPH competencies were coming close to that. And we thought, well, we can't keep doing this in little pieces. So we said, you know what, we need one big task force to look at this whole thing, to look at the entire continuum or sphere of education in public health. So we put the task force together. Now, we might not have done it this way, but because there was such demand for us to define undergraduate degree parameters, we started with that task first. So we put a group together, we put an expert panel together, and we spent probably more time than we needed to arguing about why were we encouraging undergraduate public health degrees? Was this preparation for the workforce, or was this education in the liberal arts tradition that would then perhaps lead to graduate study, professional degree programs? And we finally decided we didn't care. We just needed to say, what is it about an undergraduate degree? What's the what? What's the core content, if you will? And we didn't really care about why they were doing it, and we didn't care how they did it. So we put that together, and we came up with what we called critical component elements, because we didn't want to call it core, and we didn't want to call it competency, because those words have meaning. So we called them critical component elements of the undergraduate degree. And they basically look like this. We had to speak to background domains that all undergraduates we thought pursuing a public health degree should know, and you can see those there. We then developed a set of public health domains, which included understanding public health, the healthcare system, human health, determinants of health, and all the things that you can see here. What you won't see here, and if you are students or members of the faculty here, what you won't see is biostatistics, epidemiology, environmental health, behavioral sciences, and that wasn't done deliberately. This was a very organic process. The group that worked on this really thought very hard about what should be the what of an undergraduate degree in public health, and this is what they came up with. We were actually very excited about that because it then freed you to think in different ways about the rest of the educational system. We also added a requirement that there be a culminating experience. That's actually true of all undergraduate degrees. And then we were very clear to say we thought students should be exposed to the field of public health, but not necessarily required to have a practice experience. And that was largely due to some smaller colleges with growing demand, because these degrees are extremely popular, were very concerned that they couldn't possibly place all of these students in a meaningful field experience, and they really urged us to not require that. So that's why that's not a requirement. And then, as we always seem to run into in public health, there's all these other areas that are important to the development of people's knowledge and understanding of public health that aren't necessarily the normal curricular content. So things like how to advocate, how to think systems, how to network, how to make decisions in an ethical manner, those kinds of things. So that's the critical component elements. That has then led to the Council for Education on Public Health to develop a mechanism for the accreditation of standalone undergraduate degree programs, and that process is just beginning now. We then put together an expert panel on two-year colleges. As I said, when you get into the undergraduate world, you quickly learn the importance of two-year colleges in that world. Something like half of all students who get four-year degrees in this country start in two-year colleges. So you can see this is an important pipeline. It's an important opportunity, again, to provide public health educational opportunities to that broad audience. Again, in the learning outcome spirit, wouldn't it be great if everyone in a two-year college knew something about public health? In the critical component elements spirit, wouldn't it be great if students could earn credits toward a public health degree in a two-year college as they were planning to transfer? So that group is doing that work. The other nice thing about community colleges is they are community colleges. They are in communities all across the country, which means there are opportunities for those institutions to support the continuing development of the workforce, which at least today includes a number of people who have no formal training in public health, or who have training, but they need an upgrade in their skills. So these are important opportunities. We then tackled the MPH, which in some ways was the hardest piece because it's kind of the heart and soul of what most schools and programs do. And so we put that expert panel together, and they chose to focus in three areas, what they called key considerations of a futuristic MPH, design features of that degree, and then critical content of the core. So they're looking at what we affectionately know and love as the core curriculum. They're also looking at beyond the core curriculum, what should the MPH look like? They're looking at the practicum, they're looking at the culminating experience. This is a work in progress. The expert panel has done one draft on key considerations and design features that has been reviewed by a broader group. They've now, they've edited that based on that feedback. The core content is just about to go out for review, and hopefully a number of you will get that survey and respond to that, because we need all the input we can get. But I wanted to share with you a couple of the key considerations in the design features so you could see where this particular panel is heading. So these are just examples. So there's a long list of key considerations, and here's a couple. The MPH degree should be clearly distinguished from the BSPH and the DRPH, as the BSPH becomes the entry-level degree in the field, and the DRPH emerges as a high-level degree focused on public health leadership and management. That was actually, this generated a lot of discussion. What is the entry-level degree for public health? It's been the MPH. But now that we have hundreds of BSPH degrees out there, and more emerging in schools and programs of public health, not just outside of us, we have to recognize that that's the reality. So that was one of the statements. Here's another one. The MPH should be designed as an advanced degree focused on specialist education that is directly responsive to the needs of students and their prospective employers. So the group felt strongly that the MPH should give someone a particular skill set in a particular area of need to the employment world and to their own learning goals. On the design features side, accredited schools and programs should have flexibility in designing many aspects of their MPH degree, including prerequisites and experience requirements, core design, and concentrations. And this is speaking pretty directly to accreditation criteria. The folks from CEPH have been on the task force on every expert panel. They're very much behind this. So you can anticipate more freedom to schools to be more innovative, more localized, more flexible. An in-depth concentration should be a distinguishing element of a 21st century MPH degree. Again, the group feels strongly that it shouldn't just be, a sort of potpourri of courses that are of interest to you, but that you really ought to get depth of training. Having said that, the common element of all MPH degrees should be a well-designed core that covers critical and interdisciplinary content in foundational areas of public health. So the core remains a very important feature of the MPH. When you see that core content, I can't show it to you now, but when it comes out, you'll see that it is not at all like what we have lived with today, but it does lay an important foundation for then the depth of training that will come after that. And then relatedly, the practicum and the culminating experience should be considered primarily as elements of the concentration rather than as elements of the core. Meaning, if you are in a health education concentration, then your practical experience should be in that field and your culminating experience should be in that field as well. So those are some of the, just to kind of give you a flavor for where we're going with the MPH degree. A couple of other things that are going on around us as we do this work. Interprofessional education is of growing interest around the country. There's now a consortium that's been put together. They've developed a set of initial competencies, and they do include all of the clinical healthcare professions as well as public health. The IOM report of 2002, for instance, called for all students in medical schools to be exposed to public health. And this begs the question, can public health be taught in any arena? So if all medical students should be exposed to public health, that's easier done in the medical school perhaps than in the School of Public Health, or maybe not. And so that's been a point of discussion. What if we taught public health extremely well in every clinical health training program? That might not be a bad thing. And then that begs the question, it's not just health professions that engage in improvements in public health in the community, but there are an array of professions that engage in work that affects the health of the public. And you can just think architecture and urban planning and public policy and law, just to name a few. So what if we taught public health extremely well in all of those professions? What would the world look like? Back to the learning outcomes dream that we had. If more of the public understood public health, it might make our job easier. Something else happening around us, most of our sister health professions programs have moved to the doctoral degree as the terminal degree. So you used to get a master's in physical therapy, now you get a doctorate of physical therapy. You used to get a nurse practitioner degree, now you get the doctor of nursing practice. And that kind of led us to a lengthy discussion about should we be moving to the DRPH as the terminal degree in our field. And since I just told you about the MPH expert panel, you can see where we came down on that. We didn't think that was necessarily appropriate to our field, particularly if you remember that table with all the different degrees in it. We have a lot of joint degrees. Our schools and programs offer many, many joint degrees because it's very attractive to piggyback an MPH on top of name the other profession, whether it's a health profession or law or things like that. And if we eliminated the MPH, that would challenge those opportunities from continuing. And then there's other things just going on in higher ed. There's been a lot of discussion about moving away from the credit hour and the grade as the assessment of learning and looking at things like competency-based degrees where we would assess your competence and you might bring that with you before you ever set foot on our campuses and we would give you credit for that. You might show that to us by completing certain coursework. That's a whole new way that we think about learning and that has potential impact for what we do. And again, the sort of flex option idea where if you rethink credit hours and you rethink calendars, not all learning necessarily has to take place in a 15-week semester in 50-minute chunks 3 days a week, right? If you think about a competency-based model, then you could think about ways where students could hone in on those areas where they do need the training and the new knowledge. They could test out perhaps of the things that they already bring, and you suddenly free yourself from the confines of that. And then what allows all of that to happen is now the opportunity for web-based instruction, flipped classes where you study the content at home and you come together just for discussions or case studies or field-based experiences, and things like MOOCs. We know students will take advantage of those and again want to come to us and say, well, I already learned that. If you use a competency-based model, then it's easier for you to give credit for that where it's appropriate. Again, I mentioned the public health workforce earlier. We're doing all of this, we believe, in service to the public's health, and we do that via the workforce. That's why we talk about education and training, because we are presumably preparing that workforce. But that's a challenge, because we don't always agree on who they are, where they are, how many there are. I know a friend of mine likes to speak about even state public health systems, which we think we know and understand. He describes them as chronically unique. So if you've seen one, you've seen one. So how do we understand the composition and the size of the workforce, and what does that mean for our responsibility to train that workforce either in the pre-professional world or as they are out there? What responsibilities do we have to contribute to the continuing professional development of that workforce? The IOM, again in 2003, defined the workforce as a public health professional, is a person educated in public health. And we said, okay, great. Oh wait, or a related discipline who is employed to improve health through a population focus. So that tries to begin to give us a framework to think about the workforce and to think about who our target audience is as the educators of that workforce. But you can see how this is a challenge for us, and the task force will speak to this. We haven't put a panel together yet, but there's been a lot of great work done about this that we will certainly cull from. And then we just know that our world is changing in very dramatic ways. I didn't put the Affordable Care Act up here because I don't have to, because you know how that will change, how healthcare is delivered, how it's financed, how it's organized, how people receive it, where they receive it. And as part of that has been this growing interest in population health, and I put it in quotes because we don't all mean the same thing when we say those words. And so what's public health's role in population health, and what potential implications does that have for the public health workforce? I think Dean Goldman mentioned that we're anticipating a lot of retirements in that workforce. We've seen that workforce shrink. Again, it depends on how you define the workforce, because we know people have career trajectories far beyond traditional public health departments. Again, we've seen the explosive growth in the bachelor's degrees. We don't see that ending. The interest in interprofessional education is only going to grow. New technologies are only going to give us more opportunities to think where learning spaces are, who's facilitating learning, the value of a degree. This is all changing around us. And then the population is changing, not only in this country, but it's changing around the world, and we have to be mindful of that. So when we sat down and kind of mulled over how we would tackle this, I give credit to Dean Goldman and my colleague, Dean Barb Reimer at the University of North Carolina, Chapel Hill, who said, you know what, what we need to do here is take an empty room approach. We have to pretend like we don't know anything. We have to pretend like we just landed on this planet and someone has asked us to design an education system for public health. And that's hard to do. We've tried to do it. We've called each other on and say, well, what we're doing now, I don't want to know what you're doing now. I want to know what we need to be doing in the next 100 years. So that's really the goal of this task force, and why we're going around the country having these conversations, because as I said at the beginning, it's where these local conversations are critical, because this is where change will take place. And I've encouraged people everywhere I've gone, go ahead and start making change now. You don't need to wait for this report. As I said, our goal would be for the report to be old news when it comes out. So just a few questions to kind of get us going on the panel, and I want you thinking about questions you would like to ask, comments you would like to make. As I said, we're trying to meet the needs of our field for the future, not today, but for the future. We don't necessarily know what that future would bring, so any thoughts you have about that? And given whatever that future scenario is in your mind, who should we be preparing for what jobs, in what institutions, what organizations, what skills do you think they will need? And are there two-year skills that can fill some of those needs? Are there undergrad, master's, or DRPH skills? How important is interprofessional education? As I said earlier, can public health be taught anywhere? And we're actually enamored of this idea, obviously, because we did it in the learning outcomes for undergrad. So we are putting an expert panel together. As I said, it's got a law named Public Health in All Professions training programs to actually think through what that might look like. How about lifelong learning for our alumni? How about lifelong learning for the workforce? And then I put here in bold what you might consider core to the MPH, because that's something we're working on right now. So I'd love any feedback you had. The other thing that I didn't mention, but I'll say it here before I step down, is we haven't talked about it as directly as some of these other things, but we are preparing DRPH graduates. We're also preparing PhD graduates. And one of the things that comes up often in the conversation is, are we preparing those students sufficiently to be the learning facilitators of the future for this workforce or this thing that we're doing? Are we preparing them sufficiently to do the public health research, to provide the science base, the evidence base for this future? And I think that's an outstanding question. It goes right back to the Welsh Rose report, where they said very clearly they thought the science of public health was as important as the practice. So with that, I will step down and turn it back over to Dean Goldman.
Thanks again to Donna Petersen for coming to give us that wonderful introduction to the very hard work that people have been doing around the country to take a serious reexamination of public health education. We're fortunate today to have a panel of speakers who are going to begin to address some of the questions that Dr. Petersen raised, and I would guess we'll probably ask some new questions, as this is the nature of things. And we're going to be starting off with Dr. Howard Koh, the Assistant Secretary for Health for the U.S. Department of Health and Human Services. In this role, Dr. Koh oversees 12 offices, including the Office of the Surgeon General, the Commission Corps of the U.S. Public Health Service, 10 regional health administrators across the country, and 10 presidential and secretarial advisory committees. His office is also responsible for an array of interdisciplinary programs related to disease prevention, health promotion, and the reduction of health disparities, among other critical health areas. I should say his office is also the employer of many of the graduates of our programs across the country, including our program here at George Washington. Dr. Koh previously served as the Harvey V. Feinberg Professor of the Practice of Public Health, the Associate Dean for Public Health Practice, and Director of the Division of Public Health Practice at the Harvard School of Public Health. Dr. Koh graduated from Yale College and the Yale University of Medicine. He holds an MPH degree from Boston University, and there are many other things I could say. He came to his position with many qualifications in public health, and I think brings to this topic many important perspectives. After hearing from Dr. Koh, we will be hearing from Dr. Jon Andrus. Dr. Andrus is the Deputy Director of the Pan American Health Organization. He is also, I'm proud to say, a Professor of Global Health here at the George Washington University. Dr. Andrus has 25 years of experience working in developing countries and has published numerous scientific articles. In 2000, he received the Distinguished Service Medal, the highest award of the United States Public Health Service, for leadership in working to eradicate polio in Southeast Asia. Dr. Andrus holds a BS degree from Stanford University and an MD from the University of California at Davis School of Medicine. Finally, you will be hearing from Dr. Rajiv Ramal. Dr. Ramal is Professor and Chair of the Department of Prevention and Community Health in our School of Public Health and Health Services here at the George Washington University. Dr. Ramal has 20 years of experience in health communication and risk communication research. His most recent work focuses on developing, implementing, and evaluating HIV prevention interventions in sub-Saharan Africa. Central to his work are the tools of social and digital media, mass communications, interpersonal communication, and innovative mobilization of community resources. Prior to joining the George Washington University, Dr. Ramal was faculty member of the Department of Health, Behavior, and Society, and also Senior Evaluation Officer at the Center for Communication Programs at the Johns Hopkins Bloomberg School of Public Health. He holds a master's in journalism and communication from Southern Illinois University and a PhD in communication from Stanford University. I want you to join me in welcoming all of our guest speakers for today's events, and we'll now invite Dr. Koh to come up to the podium.
Thank you so much, Dean Goldman, for that warm introduction. Welcome, everybody. It's great to be here at GW. We've had many wonderful public health announcements and celebrations in this room, and GW has been such a great partner for us at HHS. So thank you for hosting this really important forum for the future of public health education in the 21st century. Let me start by thanking Lynn herself for being such a great leader. I've known Lynn for a long time. She's a phenomenal public health leader, researcher, and now a wonderful dean here. So you here at GW should be very proud that you have such a distinguished dean at this critical time in the school's history. Let me thank Dean Petersen. This is a phenomenally important national initiative, and what she and ASPPH are doing is critically important for not only schools, but indeed for the nation at large. So congratulations, Dean Petersen, for launching this, and looking forward to seeing what the report looks like at the end of next year. I am really honored that I'm part of an all-star team presenting to you. Dr. Andrus from PAHO is a longtime colleague and friend. You will see his global perspective in action in just a couple minutes. He's done such a wonderful job at PAHO. And it's great to meet Chairman Ramal here. It's great to have his global perspective as well. And by the way, I am accompanied today by my Director of Communications in my Office of the Assistant Secretary for Health, Tara Broido. Where's Tara? There she is. And Tara is not only a wonderful communications director for my office, but also a GW graduate, both undergraduate and the School of Public Health. So Tara, welcome home. Thanks for helping me set up this wonderful speaking engagement today. So I'm pleased to see all of you, but particularly want to speak to the students in the room. Can the students raise your hand? Just want to see who you are. Great. You are the future of public health in our country. And I can say that I have spent a lot of time thinking about health education and public health education as a physician who's trained and boarded in a number of areas and cared for patients for over 30 years. As a public health professional who's worked in a public health school and was an associate dean of public health practice. As a former state health commissioner for Massachusetts under multiple governors for almost 6 years. And now as the Assistant Secretary for Health. And through that journey, literally every day, I think about how we should be training the students of today to be the leaders of public health for tomorrow. And let me say to all of you, but particularly to the students, thank you for taking on public health as your profession and your mission. There is no other field I can think of that has a more awesome mission than our field. The mission to uphold the health of others. The mission to help all people reach the highest attainable standard of health. That phrase from the WHO that we all love so much. There's no other field that can inspire so much as when we see leadership in public health in action. I'd like to state, and I'm sure you all agree, that we have an unbeatable mission in this field of ours. So it's one that's endlessly fascinating and one that inspires me every day. And the work of our field in public health is profound. It's imbued with meaning. They call it public health, but it's deeply personal for each and every one of us. And so when you connect with another person in public health and you make a new set of collaborations or form new partnerships, that's a thrilling experience that happens to me just about every day in my job, and it gives our work tremendous meaning. There is a spirituality to this journey, which I think is unbeatable. So even though I started my career as a traditional clinician, going out to care for patients and cure them and support them in the traditional way, I've gravitated to a policy and public health career because of this calling. I really feel that it's a calling that we are all hearing. And also our field, I believe, is rich for the potential for leadership. Because if you step forward with a mission like this, which is unbeatable, and you go into this field, by definition, you are saying the status quo is unacceptable, that we need our community to be healthier, regardless of how you define community in a local, national, or even global perspective. And when you enter this field, you say, I think the status quo is unacceptable. I think the health of the public should be better. And I think that I can make some sort of contribution. And that's a very strong statement on your behalf and a strong statement of your leadership. You don't have to know what the precise answers are. In fact, it's very difficult to start a journey and know what that answer or answers might be. Just the fact that you're willing to step into the vortex, step off the sidelines and get involved really makes a difference. But let's face it, our field is also fascinating because of the incredible challenges that we face. And Dean Petersen reviewed some of those challenges, as well as did Dean Goldman in her opening remarks. The problems we are tackling are enormous in scale. They stem from highly complex reasons that are often deeply rooted in the past. So solutions are difficult to gain and even harder to sustain. The longer I do this work, I think it's one thing to start a public health initiative, but to sustain it over time, year in and year out, generation in and generation out, that's the biggest challenge of all. So something that we all need to recognize as we start this journey. There's a vast array of stakeholders that we need to interact with through our work, some of whom are familiar to us, but most of whom are completely unfamiliar, especially at the beginning. So we need to develop those skills to really connect with people that we don't know, who are working in disciplines that are unfamiliar to us. And our test as public health leaders is how we resolve these challenges by working with partners, often untraditional partners, and working in areas that fall well beyond the control of any single authority. In fact, the answers to public health rarely come from any individual, but they must come from working in partnerships, collaborations, and in teams. That's why public health leadership is so different, in my view, than some traditional models of leadership that we've heard about in the past. We have an increasingly globalized world, populations living longer, so we're addressing more issues of quality of life as well as quantity of life. We're encountering more disparities in the world of public health, literally by the day, and this is an issue that concerns all of us professionally, and me personally as an Asian American and as a son of immigrants. This is very personal work to me. And then last, but certainly not least, they call it public health because we do our work on a public stage. We are transparent, we are open with our craft for all the world to see, and anybody can step up and criticize, which they are often happy to do. That's the nature of our field. So in short, we have many giant obstacles, but the challenge and the opportunity can be that can we take these giant obstacles and turn them into brilliant opportunities that demonstrate public health leadership? That is the opportunity, I believe, that's before us right now, talking about 21st century education. So as we revisit and revision for the future, we need, from you students now, future leaders who are willing to embrace this ambiguous new world that we are in, be willing to be in it for the long haul, and I think the most effective practitioners and leaders are those who absolutely persevere through the ups and downs of public health. If you want a quick win and immediate gratification, this field is not for you. So the public health leaders that I know and respect the most are those who can really hold on to mission, sustain that mission, and persevere in the toughest times. And we can think of many examples right now in our country. We need in you, the future leaders, people who are willing to make decisions in public today based on always imperfect data. And you don't get that in a classroom. In a classroom, you're looking for better data, and you have the luxury of not having to make any decisions, but in the world of government, certainly, we in public health positions have to make decisions today or immediately based on imperfect data and know that that's the best we can do and that we can live with that while hoping for a better set of decisions tomorrow. In short, we need leaders who are willing to hold on to their mission and ideals and dreams, but be willing to practice in a world of limits and constraints, because let's face it, in public health, the needs are always infinite, but the resources are always finite. In my view, the public health leader of tomorrow has to be someone who enjoys interdisciplinary work. It's one thing to go to a great school like this and have a concentration in one particular area, but when you go out into the real world of practice, you have to literally practice all those disciplines at the same time while interacting with all these stakeholders. And so you have to be humble about what you know, be always willing to learn more, be a student for life, and be humble about what you don't know, and always send the signal that you want to learn from the people around you. The best public health leaders I know are those who say, I reject the status quo. What's happening right now with health is unacceptable. I am willing to make a contribution to make a difference, but I don't have all the answers. I need you and you and you and you to step forward to share what you know with me so that we can all work together to make a better difference for our community and our society. I've often thought that in the world of public health practice, there are 7 Ps for the stakeholders that you need to interact with. First, policymakers. This is where the theme of interprofessional education comes in. And we at the Department of Health and Human Services are now increasingly interacting more across government with people from the Department of Agriculture, from Housing and Urban Development, from the Environmental Protection Agency, from the Department of Defense, the VA. You have to be a person who is willing to push yourself to get out of your silos and build those bonds with other policymakers across society. The second P is purchasers. Third P would be providers. I'm a physician, that's one type of provider, but there's many others. A fourth very important P is the press. And again, that's why it's very important that I have my communications director, Tara Broido, with me today. This is one major area when I think back on my own public health school education where I wish I had heard more about the importance of interaction with the media. And when you interact with the media on a regular basis, as many of us do in our public health positions, you have to really focus on succinct communication, getting your message across, sometimes in a line or even a phrase, knowing that you might have only a couple seconds in an interview to get your point across. So the most effective public health leaders I've seen are those who can speak simply and succinctly in just a line or even a phrase. I would highly recommend that practice of succinct communication, both oral and written, by the way, be a major focus for future education. And while I'm on this topic, in jobs like mine, every half hour somebody is coming in to brief me on areas that I may not know very much about, and they have to very succinctly get me from zero to a working knowledge of the controversy at hand, and then engage all of us, me and others, to help start a discussion about how to solve those problems. And believe me, when you're in those briefings day in and day out, year in and year out, you just treasure people who can speak succinctly and get to the point and communicate with you so then you can work as partners to move on. The fifth P is for passionate advocates. And I say this as one who is a passionate advocate myself. I started my career as a cancer control and tobacco control advocate, which I still feel I am in many ways. In my career, I've had now the chance to work with many passionate advocates. I've now concluded, by the way, that there is an advocacy group for every organ in your body from the top of your head down to the tips of your toes. And they all come in, and there's good news and there's bad news about passionate advocates. The good news is that they're absolutely passionate about what they believe, and they will not rest until everyone else agrees with them. And the bad news is they're absolutely passionate about what they believe, and they will not rest until everyone else agrees with them. So that's the world of public health practice. And again, I would encourage that our future curriculum really have attention to how advocates work, what makes an effective advocate. Perhaps you are one yourself. I can tell you that I have seen all forms of advocacy in my job. Some of it works extremely well to create positive change. Some of it doesn't work quite as well, and we need more attention to that. The sixth P is penurious budget officials. Sort of cheated on that one, because the budget issues are omnipresent whether you like it or not. And I think it's critically important to talk about not just the ideal ways of solving problems when you're a student, but perhaps put you through budget exercises where your budgets are being cut after you have a plan of how you're going to spend money. Do that in groups with advocates sitting around. These are some of the exercises I used to conduct when I was teaching in a public health practice setting. And I think if you feel that pressure, it gives you a much better idea of what world you're about to enter when you go into the outside world of practice. And then the seventh P is the public. So as I close, let me thank you for having this town hall, for raising these important questions, for talking about training the public health leaders of tomorrow. I would like to suggest that the public health leader of tomorrow is somebody who can embrace the ambiguous, who can cultivate interdependence. A leadership role for public health is cultivating interdependence because you can't do it alone. A public health leader who's effective is somebody who understands himself or herself well, knows your own strengths and your own limitations, and know where you can go to get help and support, because we all need that to build better collaborations and partnerships to make our communities healthier. The more you concentrate on your interpersonal skills, we don't talk about that very much in any sort of setting, is absolutely key. Because if you can connect with a person interpersonally, that could be the beginning of a wonderful public health partnership. I often say to my colleagues that I'm amazed in this day of social media that people go to meetings, sit next to other important people, and spend their whole time on their BlackBerry, when if they sat up and just turned to the right and left and just had a conversation about how that person was doing, how their family was doing, how their dog was doing, even if they don't have a dog, that's the beginning of a conversation and a possible public health partnership. That is the key to public health success and leadership, in my view. And as you connect with people around you, can you view every person as a potential public health partner, whether they realize it or not, whether you realize it or not? And can you build a bond where you encourage the heart? That's a wonderful phrase from Kouzes and Posner, leadership gurus, which I love, because fundamentally we are people dealing with other people, trying to encourage the heart. So as I finish, again, to the students, thank you for choosing public health. And I would encourage you as you go through this journey to be absolutely constant in your sense of mission in public health, but absolutely flexible in how you reach that mission. And also, absolutely be a student of leadership for the future. Here's a wonderful Chinese poem from the philosopher Lao Tzu, which I think summarizes it all. And it goes like this, and this is about leadership. Quote, "Go to the people, learn from them, love them, start with what they know, build on what they have. But of the best leaders, when their task is accomplished, their work is done, the people will remark, 'We have done it ourselves.'" Thank you very, very much. And now it's my great pleasure to welcome a wonderful public health leader, my friend Dr. Jon Andrus, the Deputy Director of PAHO. Okay, thanks, Jon.
I'm delighted to be here. Thank you, and that was a great presentation, Howard. I want to thank the Dean also for inviting me to this event. I'm going to speak from the perspective of global health and highlight the critical need to be training our future public health professionals in a way that commits them to being highly dedicated and passionate, as Howard mentioned, to reducing health disparities that exist virtually everywhere in the world. Let me begin by noting a few facts that'll help me frame the take-home message that I would like to leave you with today. Historically, public health in the Americas and the schools of public health, both public and private, have been the voice for the right to health, health for all. And they have been key in defending marginalized groups and communities, the promotion of inclusive social and economic policies based on the values of social justice and equity. It will be critical to sustain that role in tackling emerging, more complex problems well into the future. For the first time in history, chronic diseases are killing more people globally than infectious diseases. That is not to say infectious diseases are not important, such as AIDS, malaria, and tuberculosis, and the vaccine-preventable diseases, but the shift in the epidemiologic trends clearly highlights the critical need to have a more balanced approach as we strive to tackle the world's health problems. We must avoid the tyranny of sequential thinking, and we must recognize and target our approach to health to the most marginalized, the most underserved, where most of these diseases are occurring. The social determinants of health, such as poverty, gender, education, ethnicity, geography, and access to health services, require an all-of-society approach, an approach to partnership and coordination that Howard referred to, often out of the traditional skill set of our public health professionals. The adverse health consequences of the social determinants will require solutions outside of health, obviously. A more what I call enlightened set of skills will be required for global health professionals if they are to lead. The success of public health measures against unsafe water and sanitation and the eradication and control of vaccine-preventable diseases are arguably the two greatest contributors to the increased life expectancy we now experience in the Americas. Folks are living longer, but developing more chronic diseases at substantial costs to national economies. The effects of climate change have the striking potential to bring unexpected emergencies and catastrophes to nearly all of us in this room. Neglected tropical diseases, once thought limited to the jungles of Central America and the Amazon basin, are now in our own backyard. As an example, Chagas disease is the leading cause of cardiomyopathy in the tropics of the Americas, causing syndromes that mimic atherosclerotic heart disease. Chagas is a crippler that zaps the energy from its victims and progresses insidiously into adverse outcomes such as congestive heart failure and death. The kissing bug that transmits the disease is now across the South, particularly in Texas. The CDC estimates approximately 300,000 cases of Chagas disease existing there. Who would have thought 20 years ago that Chagas disease would be emerging in our own backyard, the southern states of the United States? But in trying to define the true burden of Chagas disease, the evidence is scant. Local public health departments lack the ability to manage and use the little evidence that they have in hand, and efforts to conduct the necessary research to generate the evidence is clearly lacking. The point is, we live in a much more complex world that requires more than ever a highly trained and knowledgeable cadre of public health professionals. Effective prevention and control of the conditions that I have cited, chronic disease, the unfinished agenda of infectious disease, social determinants of health, climate change, emerging infections, all these require having interventions grounded in evidence. Future health professionals must have a better understanding of the use of evidence. What is rock-solid evidence? When is it weak? When is it circumstantial? Here's the crux of the problem. Dr. David Butler Jones, a former chief medical officer of Canada, once said, very simply, public health is easy to do poorly. How do we train the next generation of professionals to get it right? Now, here is my bias. I believe the language of public health is epidemiology. And here is also the link to evidence and research, and also the populations we are trying to serve. Whether you work in the field of communication, monitoring and evaluation, policy, program management, whether you're a nurse, a sociologist, a behavioralist, you absolutely need to be well-versed in the language of public health, and I believe epidemiology. The guiding principles of epidemiology can be applied in most cases to address the spectrum of challenges ranging from those I mentioned, chronic diseases, social determinants, and so on. And again, evidence is the key. As Senator Moynihan once said, you are entitled to your own opinion, but not to your own facts. Mark Twain was a little bit more cynical when he said, get your facts first, then you can distort them as you please. So taking it a step further, future professionals must speak with evidence while also absolutely unwavering in protecting the truth. The next generation of professionals must also embrace shared guiding principles, the fundamental one of which I mentioned at the beginning, a passion and commitment to reducing disparities in health. In that context, to make a difference, the next generation of professionals will need to be great leaders. Howard clearly articulated that. And at the risk of oversimplifying, their leadership should embody the 3 V's: values, vision, and valor. The values of integrity and dedication, the vision to put those values into practical strategic frameworks or plans going forward, and finally the valor or courage to fight and ensure that plans are acted upon. Regarding this last point about action, Tom Frieden, the director of CDC, put it well when he said, a solution that has great potential and always will. The point is, it doesn't get implemented. It sits on a shelf. One other leadership trait, again, that the former speaker referred to, and which is often overlooked, I believe, is perseverance in public health. Perseverance is absolutely fundamental, where results don't often happen immediately, but over months, years, and decades, with several unexpected events or failures along the way that must be overcome. Winston Churchill captured this notion quite well when he said, success is the ability to go from failure to failure without losing your inspiration. To that end, role models are absolutely essential also in our training programs. Role models need to be educators, and I believe that educators need to be role models. They should set the tone for students and teach and lead by example. In global health, experience is gold. I laud the MPH program here at GW, where students have the opportunity to serve 2 years in the Peace Corps in developing countries while simultaneously advancing their MPH degree. And again, experience, and more experience. The Peace Corps experience exemplifies personal sacrifice and dedication that is invaluable in public health. And such experience, honestly, will flag employers to individuals with exceptional credentials. At PAHO, we offer students the opportunity to fulfill their practicum and their internships, clerkships, that will allow them to tackle important issues, producing tangible products and services that are win-win. Win for PAHO because we have a product or service that has been provided to the communities and countries we serve, and win for the student because they're gaining and accumulating that necessary experience. There are other training models throughout Latin America and the Caribbean where educational programs prioritize community service, particularly in communities of poverty, communities that are underserved. These best practices actually come from many countries, but I want to note those that come from Argentina, Chile, Ecuador, Nicaragua, Peru, and a few others. I had the opportunity to be at an event in Thunder Bay, Canada last year highlighting the best practices. So, in summary, my take-home message for you today is the following. Among the many factors, many of which were highlighted by Dr. Petersen, among those factors that will help revision the education of our future public health professionals, I believe that education models that incorporate these fundamental elements of evidence, epidemiology, the leadership virtues of values, vision, and valor, the critical influence of role models and mentorship, and lastly, perhaps most importantly, experience, especially experience through service. I want to thank you again. I'm deeply honored and moved that you would take the time to come and listen to these points. So thanks again. And please join me now in welcoming our next speaker, Dr. Rajiv Ramal, who is Professor and Chair of the Prevention and Community Health in the School of Public Health and Health Services here at George Washington University. Thank you.
First, I want to thank all the students who have braved the hour and a half to be here. Thank you all for coming. And thank you also to my previous speakers, to Dean Petersen for spearheading this effort, for Dean Goldman for organizing this event, and the previous speakers who have really highlighted some of the key things that we should all look out for as we move ahead. Let me start by sharing with you a story. One of my favorite teachers in graduate school was someone by the name of Dr. Cliff Nass, who unfortunately passed away about 3 weeks ago. But he left behind an idea that is very provocative, I think, especially for someone like me who was trained in communication research. He left behind a very popular book called The Media Equation. And what the media equation basically says is that our brains are incapable of distinguishing between mediated reality and reality itself. Now, that's a very provocative idea, and it comes from this underlying notion that if we were to think about, how long Homo sapiens have been on Earth, put that on a continuum from the left side to now on the right side, and on that continuum, you plot where media or mass media first came on the scene, right? So you would see a small sliver of when media came on the scene compared to this very large line when we existed without media. Now, why is that important? That's important because what it means is that our brains have not had enough time or enough juice, if you will, to adapt to a mediated environment. So therefore, at a very fundamental, basic level, we interact with mediated reality as if it were real reality, right? If you don't believe me, think about the last time that you saw a very scary film. If you're alone at home in an evening and you're watching something on television and that's getting really scary by the second, what do? You say to yourself, it's only a movie. Now, why would you have to say that if until that point your brain wasn't treating that movie as if it were real, right? So the point being that we are asking a lot of our brains in this modern world. And if we were to go back to that continuum of time and think about the unit that probably most accurately captures time, particularly when we think about social change, the unit would probably not be something linear like seconds. It would probably not even be seconds to your exponential degree, it would probably be a logarithmic scale. In 1963, if you think about social change, right? In 1963, the number of patent applications in the US was about 90,000 that year. In 20 years, the number of patents had increased to 109,000. And that's about roughly 18 or 19%. In the last 10 years, the number of patents has grown from, in the last 20 years, sorry, has grown from 88,000 to 576,000. So that gives you a scale of the kinds of change that we are all exposed to on a day-to-day basis. Now, why is any of this important in our discussion today? And I would argue that all of this is really important because what it tells us is that social change is happening very, very rapidly, and yet in public health, we're using very static terms like competencies to talk about what we need to do moving forward. You know, if I relied on the competency that was really important when I was in graduate school, I would be dealing with punch cards right now, because that was what was really called for. So moving forward, I would argue that, you know, being in an educational institution like ours, we do not have the luxury, we do not even have the ability to be on that treadmill that is accelerating by the second. We can't do it. We wouldn't be able to do it even if we tried. However, what we can do is we can train future public health scholars, future practitioners, in just one competency, and I know I need to come up with a better word than competency for this, and that is, how do we increase people's capacity to learn? Because after all, that is the one constant that we hope all our students will participate in for the rest of their lives, that they will continue to learn, they will continue to adapt, and they will continue to exist in a world that is changing very, very rapidly all around them. Let me end by saying that all the discussions we have had today in framing what's going to happen for the next 100 years, all this is really important, critical stuff, much of which we can engineer now, most of which we probably cannot. But we can certainly set the environment and the conditions under which our future scholars, students, and practitioners are going to operate. And let me leave you with one parting thought, which is that being in an educational institution like ours, of course, service is important. Of course, practice is important. Of course, research is important. But what is really important at the end of the day is that we end up with students who leave our walls and at some point in their lives begin a sentence with the two words, "I wonder." Thank you.
Okay, we're running a little bit late, but I'd like to have a lightning round of questions, and I invite our panelists to come back up to the chairs in the front, and invite all of you to come up to the microphone if you have any questions or points that you want to make. And we're seeing if we can maybe have an extra 10 minutes in the room. I'll let you know if we get that. So come on up. And actually, I think we have a plant in the audience, maybe, or did. If not, I'll ask the first question, or perhaps make the first point. So I know, and Donna, I'm going to turn to you, and then I'm going to come and sit down, and I do want to see some of you pop up and come to the mic. But I think that one of the issues has to be that even though schools of public health have only been around for 100 years, that's not even that long, really, and so it's not an older profession. Actually, it's a newer profession, and that we've worked very hard to attain the kind of education that we do deliver, and to meet all of the standards, and so it isn't easy, actually, to talk about change. And just to be frank, it's not that easy to talk about change. And how can we, as a community, embrace change and as Rajiv, said, become a community that's more about learning than trying to know, and use a well of knowledge and competencies that we gain at one point in time for a whole lifetime. Perhaps you could start that, and we can hear from the others too.
Thank you, Dean Goldman. Yeah, I think that's always a critical question. People don't like change by their nature. People don't like change. People like what's familiar, they like what's comfortable. And in fact, I think that's what we have seen, that we have gotten comfortable. We have continued to educate students in the same way for many years. And you go out the door, and we expect that we've given you what you need to do whatever job it is you choose to do. And what we've heard from our colleagues out in the field, other professionals, and our own graduates who come back to us and say, well, you know what, you didn't really teach me what I needed to know. You didn't give me the lifelong skills that I need. And I think we've heard a lot of them expressed here today. The commitment, the passion, the ability to work across sectors. I loved when Dr. Koh said, to work with people you don't know in areas that you are not familiar with. And the idea of teaching you to learn, teaching you to think, teaching you to understand systems. We haven't done that terribly well. And in some ways, we've done it to ourselves. We've created structures that have forced us into boxes and, as I said, semesters and credit hours and this many courses in this many areas. And we haven't allowed the flexibility for you as students to come in and learn what you need to learn to do what you need to do, and sort of imbue you with the kinds of attitudes and the values and the valor and the virtues and things that you've heard about here. So change will be difficult, and particularly change in this area is challenging because it's not as tangible. It's easy to say what a biostatistics curriculum should look like. It's not as easy to say what a course in creating, nurturing, and understanding the evidence. That's a different approach. So this won't be easy, but what I've heard in my travels around the country, and I've enjoyed these conversations very much, is perhaps a frightened reluctance to change, but an understanding that change must take place if we are to do what our field needs for the future.
So actually, Pierre Vigilance is here, and I'd asked him if he might be willing to get up and say a word or two. Dr. Vigilance is our Associate Dean for Public Health Practice at the school, and also in the past has served as Commissioner of Health, not only for the District of Columbia, but also for Baltimore County. And I know from personal experience that the practice of public health, I recently saw that movie, All Is Lost, where the sailor lost everything and had to go back to using, the sextant and the old-fashioned nautical maps to figure out where he was. And I sometimes felt that way in public health. That phone call that you would get at 4 p.m. on a Friday afternoon about something you had never heard of, and having to assemble the tools and the people in order to even figure out how to grapple with that. And so I don't know, Pierre, if you have thoughts about that.
Thank you, Dean Goldman. So the challenge that you just referred to was that's a standard Friday afternoon in local public health practice. 4 o'clock phone call about something that you had no idea about. Most people are not necessarily where they're supposed to be at that time of day.
Everybody's gone except
on their
you.
way out the
Yeah.
door. And,
That's right.
and having to try to get the information together. And I think that's, to me, that was part of the fun, but it was also the reason why I weighed a whole lot more and had a whole lot more hair. Sorry, I had less hair than I do now. That's not even possible, is it? Maybe it was my armpits, I'm not sure. But still, the issue is that stress was certainly a major issue with respect to dealing with that. And I think that having people around you who can, to the point that Dr. Koh made, speak succinctly to things, are able to make those pitch statements quickly, are able to distill information, analyze things, problem solve sort of on their feet, and quickly give you what you need to have, I think is very important. I think that we look for that, and I really valued my communications folks, the people who worked with me from that particular perspective. I really valued the fact that many times they didn't necessarily come from public health. And so the fact that they didn't come from public health allowed them to think of solutions and issues that were probably quite plausible and reasonable, but didn't necessarily come out of the boxes that I think that Dr. Petersen just mentioned that we typically deal with. And I think that the reason why we deal in those boxes is frankly a function of funding. I think that the way that funding streams come down, until the community putting prevention to work grants and until the CTG grants came out a few years ago, we were dealing essentially with money that was coming for particular purposes. And when that funding came down for those particular purposes, people worked around those particular boxes or in those particular boxes and didn't see the need to come outside of them. And I think that that day-to-day grind in a box means that when the call comes on a Friday afternoon at 4 o'clock, it is more challenging to find people who are able and nimble enough to think outside of the box, because every day they are playing around within the four walls of a box. And that box, I think, is strongly determined by funding, or at least has been. And it's been really good to see a much more diverse set of partners coming to the table and being engaged by public health and with public health, so that those 4 o'clock calls on Friday afternoon are dealt with people who can actually handle them, as opposed to folks who are really scrambling and trying not to tear what little hair they have out.
The amazing thing for me, Pierre, was always that no matter what had been done to your budget the week before, there was the assumption that whatever it was at that 4 o'clock on the Friday afternoon call, you would immediately deal with it, right? And I think Dr. Koh mentioned the resource exercise that he uses, and what about the resources issue, especially in local public health?
So every year, public health budgets are cut, and every year organizations like APHA, AASHTO, NACHO, et cetera, advocate very well, I think, for sort of reductions in those cuts, or at least keeping level funding. The problem is that I think that one of the biggest problems we have in public health is that people are not clear on our value. People are not clear on what the return is on that investment. And so businesses make a very good case for that. Uniform services make a good case for that. Education makes a good case for it. Transportation, housing, etc. But for some reason, public health has not been nearly as effective in making a strong value statement. And when business people speak to me about value statements from an individual perspective, they want to know, what problem are you solving that no one else can solve? And our challenge is that a lot of different people are solving many public and population health issues without necessarily having either a public health background or public health people in their ranks to assist them with that. And I think that that's a function of a couple different things. One of them is that we're not really taught effectively, nor do we teach effectively, how to make the pitch, how to show the value that it is that we have, and how to have that be something that people feel that they can't live without in their organizations, no matter what kind of sector they're in.
Thank you. John?
If there's not another, I can add a couple of themes that are a common theme that's emerged is this notion of change and the challenge of managing change. A good book you may want to read. I read it on a flight, a long flight, but it's called Who Moved My Cheese? Mm-hmm. And it's really, it's a parable that really provides great insight on how you can develop better skill set to manage change and deal with it. The other thing about change is to work with people who are optimists. Bill Fahey once said, surround yourself with optimists and only use pessimists as consultants. The optimists will get you through that 4 o'clock call. There you have a can-do attitude. They're fun to work with. If you can develop that skill as well, you'll be everybody will feel that you're a valuable added member to the team.
Interesting.
I'm learning that whereas politicians talk about getting the call at 3 a.m., if you remember the previous elections, public health officials get calls at 4 p.m. on a Friday.
On Friday.
On Fridays.
Yeah.
I wanted to just chime in and say that one of the things that Dr. Koh talked about was passion and the pursuit of passion. And I think most, I would say that most undergraduate majors in public health, before this degree has really taken off, and become an established degree like psychology or sociology or what have you at the undergraduate level. I would assume that many public health undergraduate majors are here because of their passion. And whatever we do for the next 100 years, I think that framework should really try to tap into that passion and form and allow that group of students to really charter the next course of action.
So if you could identify yourself.
Bob Griss with the Institute of Social Medicine and Community Health. I like very much the focus on values and passion, but I don't see as clearly a statement about public health being driven to social justice. That is, to me, what distinguishes public health from everything else. It's a secular form of social justice. And what is totally missing from all the presentations so far is a consideration of the political determinants of health. You're preparing people for shrinking budgets, so they need to be flexible, they need to be optimistic. But you're not talking about social movements that are necessary to counter the political determinants of the social determinants of health. And I think that formulation is more realistic about what the challenges are and explain why public health in the US is different from public health in Europe or in Canada. And I think that if you look at those differences, we'll have a clearer sense of what challenges we need to meet to be more effective in driving the society, so that public health isn't just responding to the 4 o'clock telephone call of a disaster. I wish all disasters happened more quickly at the same time. Then I think we would be in a better place to mobilize people. But they come at these inconvenient times, and fighting them individually is really not a substitute for the social movements that I really haven't heard addressed in the presentations.
Thank you very much. Any comments to that?
I couldn't agree more. I think that's absolutely correct. And I think if anyone sort of, just takes a glance at the state of public health, universal health in this country, the political ramifications just are there for everybody to see. And that's not true just of this country. I think that's true in most parts of the world. No question about it. I think we do not, by and large, train our students to tackle those issues, particularly with an international flavor, because what works in the US is not going to work in Malawi, where I work. So I think developing that kind of political sophistication is absolutely essential. And we see that in the environmental movement, until people really rose up and said and demanded environmental justice, we didn't even have the cleaning up the Superfunds, for example. So, absolutely.
Next question.
Yes, I'm Caroline Batty from the American Public Health Association. And yes, Dr. Vigilance, I did work with the Department of Health for a number of years and left just when you came, unfortunately. But, what I just want to say is that we as public health professionals, we are extremely, well, and do what we do very well is make our presentations and, prepare what we have to say to the students and to the people who are sitting in this room. But, however, one of the P's that Dr. Ho mentioned was the last P, the public. And that's what's really missing, from, these conversations. I have been to many, many meetings and, made presentations to many meetings over the years that I've been in public health and the American Public Health Association. And, I've made this remarks to similar to this, what I'm saying, over and over and over again, until I can tell my neighbor, or until he can stop asking me what I do, and I can really give him an answer which is satisfactory to him. I don't think that I've really made a difference in the work that I've done for so many years. because I tried to explain to him, what it is that public health is, but he doesn't seem to really get it. And these are intelligent people. Well, how does it affect me personally? That's what he's saying. So I have to really address the previous person who spoke in terms of social justice. And we really need to pay more attention, to that. At this point, change is happening rapidly at some point, but slowly among the P generation, the last P that Dr. Cole mentioned. Thank you for the opportunity.
Thank
I have to
you.
go to the meter now.
Thank you. It is interesting that when we talk about the fight, for the resources for public health, we talk about professional organizations, including our own, the schools and programs of public health, the American Public Health Association, others. But is that really a constituency? Who really is the constituency? And I do see even in my own work that when we're raising support for schools, that my colleagues in medicine have these people called grateful patients.
Yep.
And I don't have the grateful non-patients. I don't have the people standing in line. I'm so grateful to the School of Public Health that I'm not a patient, that I'm healthy. That has not really come home to people, that were even visible in their lives, much less have made an impact. Yes, if you could identify yourself, please.
Yes. Good afternoon. I'm Meredith Waters. I am a recent graduate of the undergrad public health program at GW, and I'm currently pursuing my Master's of Health Administration. So I have a question that's not really directed to anyone in particular, but I just know that in public health, we face a lot of health disparities domestically and abroad. And there are many people in those communities who are acting as lay health leaders and really promoting health. I just know from community health workers that we train all around the globe. And how can we deliver a public health education to those people in the communities who do not have the resources to afford a public health education or may not have the prerequisites to enter a professional degree program, but who are uniquely positioned to solve the health problems in their communities because they live in those communities every day and need the tools to legitimize their education. Because just from what I've seen at public health, I know it is becoming an increasingly diverse field, but at the top, it is still dominated by people who are not of color and mostly males as well. And I know it's I wish I didn't have to say it that way, but I don't think anyone else is really asking those questions or questioning that.
No, thank you for that question. Perhaps, John, do you want to start with it?
It's a great question. I think that, first of all, the terms of reference of the traditional approach to health and public health, as we're beginning to look at shifting tasks, and that's important because in medicine, you don't really need to be a doctor wearing a white coat and a stethoscope to treat 90% of the primary healthcare problems. So that can be done by others, like nurses who are empowered. Similarly, in public health, particularly at the community level that you're talking about, there are a number of programs in Latin America that I know of where they work with community health workers, they train them, they supervise them, they don't train them and then drop them off and leave them alone. They nurture them over time, and that supervision with the empowerment of certain tools like a handheld device or a mobile phone, communication, perhaps a laptop. Those are things that help promote their job or professional development. And I know that there are career paths. It's not perfect. There's always room for improvement. I would like to cite the example also of smallpox was eradicated some years ago, and the last person that had smallpox was in a village, I believe in Somalia, and he recently died. He was a vaccinator. So he was the last person to have the natural occurring infection and then got involved with health. I had a career vaccinating in the routine national immunization program of his country. So as an example where you've made a very important point to, because if you go to an isolated clinic in particular, that same nurse is delivering all the services, whether it be immunization, ORT packets whenever diarrhea occurs, you name it, family planning. That one person is doing it all. And to the extent that we can empower that person and provide opportunities for growth is very important.
So just to comment quickly, the task force has discussed this issue quite extensively and in a number of different forms. It appears in the 2-year college discussion. It has appeared in a discussion we've had multiple times about K-12. It appears in discussions we've had about this emergence of an entirely new workforce. You're speaking, I think, more to the natural leaders in the community and what tools can we provide them. But there's also this related emerging workforce, and you can call it whatever you want to call it, community health workers, health navigators, health coaches. And a lot of those may come out of the community and not be degreed, but be credentialed in some other way. And lastly, the task force has talked about what responsibility do we have to educate the public at large, which is not quite what you're saying, but it gets to some of the things we've done, and how can we help all undergraduates learn something about public health, which will now include 2-year college students. K-12 may yet emerge in the task force. I'm not sure. The clock is ticking. But you raise a very, very important point, and I think it gets back to something that I only sort of alluded to at the very end is how we have organized as schools and programs isn't necessarily with the social advocates that you're talking about, the people who know how to do that. It's been with people with great depth of knowledge in particular areas. Our faculty are largely PhD trained in highly specialized areas, and that's marvelous. That's where all this evidence has come from, all the knowledge that we've generated, all the inquiry. But we haven't necessarily built faculty that can train across different levels at the community level, and I think that's something that we are going to have to address if we really want to improve health. And I would urge you to read the Welsh Rose Report if you haven't, because there were 3 different groups with 3 different philosophies all vying for sort of ownership of education in public health, and the progressive movement, remember this was 1915, didn't win. But that was one of the clear options, and I think some of us would perhaps have wished that we had gone that way. So I would encourage you to read the report. I think you'll find it interesting. Thank you for that question.
Well, I want to thank you as well, and thank all of you for having come today, and of course thank our panelists and our speakers. It's been a fun afternoon, and thank you, Donna, for coming here
Thank you for
to have this session. Thanks to those of you who are with us on the webcast as well. Goodbye.
Thank you, Dean Goldman.